Your voice, your future. A roundtable discussion on healthcare in Alabama.
Hi everyone, I'm Kim Thurman.
And I'm Greg Peterson. This is Your Voice, Your Future, Local 15 News roundtable discussion on healthcare in Alabama.
The debate over Americans' healthcare dominates discussions in Washington. And like any good tug-of-war battle, both sides of the argument will show glimpses of victory until someone ultimately ends up in the mud.
Republicans and Democrats boast what they believe is best for you. But with repealing, replacement, and failing bills filling up the headlines, what actually is best for Americans can be pretty blurry.
Local 15's Darren Singleton has a look at the battle between politicians over what the best prescription is to fix the country's healthcare system.
The proposal by President Obama to bring health care coverage to millions of Americans without it did not come easy. A contentious battle along party lines lasted for nearly a year and a half. March 23, 2010, with the stroke of a pen, then President Barack Obama signed into law the Affordable Care Act, a federal mandate directing every uninsured American to purchase health insurance with the help of federal subsidies. Those who didn't will be slapped with a penalty. The act also was designed to encourage states to set up competitive insurance exchanges and expand Medicaid coverage. Most Democrats and many medical professionals celebrated the passage.
Thank you to all those members who took a really important historic vote yesterday in the House.
But Republicans who disagreed with the mandate to purchase insurance vowed to suppress it.
Democrats may have won their vote last night, but they lost the argument, and they've lost the trust of the American people.
It was an argument that would continue, renewed when Republicans took control of the House of Representatives in 2011. They vowed to repeal the act, which by now had been dubbed Obamacare. But Democrats still controlled the Senate, thwarting efforts to kill the ACA. As the implementation of the Affordable Care Act drew close, millions of Americans began signing up, so many that the website healthcare.gov crashed. After the initial enrollment deadline in 2014, more than 8 million Americans had signed up for health insurance that year through the ACA. Enrollment centers were set up here in Mobile and across the country to help citizens sign up for insurance, many for the first time. But the fight over the Affordable Care Act was far from over, becoming a battle cry in the 2016 presidential election.
When we win on November 8th, and elect a Republican Congress, we will be able to immediately repeal and replace Obamacare.
With the 2016 election, Republicans were swept into power, Donald Trump taking the White House and his party landing control of both the House and the Senate. A renewed effort to repeal the ACA began. But even with control of the White House and both chambers, Republicans found themselves in their own fight over ACA, with some in the party seeking to replace it with a stricter version but keeping key provisions of the act, while more conservative hardliners in the Freedom Caucus demanded that the HealthCare Act be tossed out completely. A new Republican plan was about to go up for a vote in the House, but divisions were too strong, with both House Speaker Paul Ryan and President Trump realizing the revised Health Care Act would fail. That one was taken off the table. Meanwhile, more than 11 million people have signed up for coverage this year under Obamacare or the Affordable Care Act. According to House Speaker Ryan, Obamacare will be around for the foreseeable future. I'm Darwin Singleton, Local 15 News.
All right, now let's go to St. Dominic's Parish Center, where Mark Hyman with Sinclair Broadcast Group and our panel of healthcare professionals are ready to begin tonight's discussion.
It's your voice, your future, healthcare in Alabama.
Your voice, your future. A roundtable discussion on healthcare in Alabama.
Under President Obama's Affordable Care Act, millions lost private health insurance coverage. Millions more were moved into Medicaid. For some, health coverage became more expensive and there were fewer choices. President Trump's campaign promise to repeal and replace Obamacare crashed and burned as Republicans sank their own proposal. What now? Good evening. I'm Mark Hyman, host of Behind the Headlines. Thank you at home for joining us. Healthcare in Alabama. Tonight we talk about it. Now we've assembled a terrific panel of experts who will address the issue and answer a lot of questions. So let's go ahead and meet them. Joining us this evening is Dr. Marsha Raulerson. She is a pediatrician. Jim Carnes, he is the policy director of Alabama Arise. Dr. Ron Franks, he is the acting chair of psychiatry at the University of South Alabama Health System. Danny Rickert, he is an executive with the University of South Alabama Health System. And Darniqua Bowen, she is a student at West Alabama University. Additional information on our panelists can be found on our website at local15news.com. We're going to be asking a lot of questions of our panelists, but you at home can also join us in this important discussion. A question we ask live on air may be yours. Local 15's Trey Lane is manning our social media desk back in the newsroom. He'll be looking for what you have to say. You can send your comments by joining us at Facebook at facebook.com/local15news or on Twitter using the hashtag #YourVoiceYourFuture. Be a part of the discussion. We want to hear from you. Panel, we've got a lot to talk about. Let's go ahead and get started. And before we get into the meat of the whole issue of health care, let's talk a little philosophy for just a moment. Mr. Carnes, I want to start with you. Why is it important for Washington to be involved in health care decisions of the people?
I happen to believe that health care is a right, and it's one of the jobs of the federal government to ensure that rights are upheld for all citizens of the country. So for me, the involvement of the federal government is just a natural part of that equation.
Mr. Rickert, what do you think?
I agree with Jim to a large degree. It's my personal opinion that healthcare is a right. I think we're the wealthiest country in the world. We spend more money on healthcare than any other country, yet our outcomes aren't as good as other industrialized nations. And so I think we have the money there. It's not necessarily spent in the right ways. From the Washington standpoint, because a lot of the funding comes from Washington, from the federal government, especially as it relates to the Medicaid population or the Medicare population, and even to some degree how we treat the tax benefit of private insurance with commercial insurance carriers and with employer-based insurance. The federal government has a huge part to play in healthcare, and so what happens in Washington, D.C. has a direct effect on citizens of Alabama.
And that's an important point, Dr. Raulerson. Let's follow up that, because never in the history has government ever created anything that is efficient, cost-effective, and provides more opportunities for the public at large. So is there a point, if we assume that the government has a role, is there a point where perhaps there's too much involvement and perhaps it's counterproductive?
As a pediatrician, I sometimes see that some of the government regulations are very intrusive into what I do as a doctor, face-to-face with the patient. However, I believe that there has to be federal involvement because I believe that every child in the United States deserves the best health care. And I don't think that should be left to individual communities. I live in a rural area. We don't have the same income in our area that may be in some other states or other communities. We depend on the federal government to help us to provide that good care for children.
And a quick follow-up to that, you raised a good point, because one of the things here at Local 15 we've heard, and our sister stations around the country have heard throughout this entire process, is often healthcare professionals felt that perhaps they didn't have quite the voice in this process that they wanted to have, and often it was left to perhaps the insurance companies, various special interests that wanted to be part of the bill-making process. And at the end of the day, when we often think healthcare is really, it comes down to the medical professional and the patient, that little kind of connection was not perhaps considered as much as possible. Is there a way we could actually have greater input from healthcare professionals?
Yes, I believe so. I think that the government should listen to representatives from the American Academy of Pediatrics. We are the professionals, we know how to take care of children, and we can talk about how that can best be done.
And Dr. Franks, kind of the same issue. What more can we do? Now, Washington is its own little creature, and it's filled with all sorts of interest groups and lobbyists, and they're always a part of the process of baking the cake. But how do we forward the interests of the rank and file citizen and those healthcare professionals who just say, I want to make people well, I want to keep them healthy?
What we saw with this attempt to pass the American Health Care Act was a number of protests that ended up in town hall meetings, to use your phrase here, with people indicating that they didn't want to lose certain benefits in the Affordable Care Act if we went to a replacement. And so the louder the voice of the people, the more likely are the representatives and senators to listen to it. And some of those meetings, as we saw on TV, were pretty rancorous. But the message got across. And I think one of the reasons that the bill failed was because many of the states that relied on Obamacare to ensure their citizens made sure that the citizens got out there and got their voice heard by their representatives and their senators.
Again, let's stay with that, Doctor, for a moment, and the whole idea of the individuals having their voice heard. And here at Local 15, we don't have a position on this, but we certainly want to challenge a lot of assumptions. There are certainly, if you look at this, there are ways to make health care a little more affordable. Just to throw out some examples, there's one allowing the individuals to control more of their health care dollars. Certainly some people use concierge services. Again, not something that a lot of people can use, but allow portability, allow trading across state lines. And some of these are elements that weren't in the original bill, the Patient Protection Affordable Care Act, and weren't in the GOP proposal. So if that's allowing the voice to be heard, how do we make that process work so that these options that are available, to some people choose to use them, are part of the process?
Well, one major flaw in the way this was rolled out was the short timeline. The difference between the Affordable Care Act and the Americans Health Care Act was that it was constricted to a very short timeline, which then impeded the kind of input that's needed, whether it's from constituents, healthcare professionals, insurance companies, pharmaceutical companies. All of those voices have to be heard if we're going to come up with a bill that truly does do its best to ensure the rights of the population to get access to health care.
Ms. Bowen, I want to bring you in the conversation because you actually put a human face on this issue, and we've got academics and professionals here that talk about it from a big picture perspective, but you deal with this every single day. You're a college student. You've got financial challenges, as every college student has. Can you tell us a little bit about what you face as a challenge today in terms of the decisions you have to make regarding your health care choices?
Well, a lot of challenges I actually have to face is I have a medication I've been on for a while, like a couple of years, and ever since I turned 19, I lost any type of help that the government was giving me. So now I have to pay at least $200 a month for my medication. So that's every month. So it's really challenging trying to do it. And when I applied for other health insurance, they basically was giving me the option whether you can pay at least almost $200 for insurance, or you can just choose your medicine. So I was like, I think the best option was just to choose my medicine.
Now, let's stay with you for a moment, because statistically, you're a young adult, you appear to be healthy, and so fortunately, the likelihood of you needing any significant medical care is less than someone who's older and sickly. But you're still forced to make a choice in terms of, I don't have a full-time coverage, so I've got to pick up the pharmaceuticals I have. Can you talk about what went through your mind as you were trying to make that tough decision? And oftentimes, we older folks tend to think of you young adults as 10 feet tall and bulletproof. You feel like nothing's ever going to happen to you. It's worth the gamble. But can you talk about that decision you went through in order, I've got to pick this one or the other one?
Well, one of the decisions were when me and my grandmother and I was choosing what decision we were going to make, we was like, we don't know how this is going to work. So when it comes to my health, I never missed a day of school from kindergarten through my senior year, not one day. So I was like, okay, maybe my health will be okay. So that's why we basically chose just to do the medicine, because I never really have too many health issues, but my main thing is my medicine. So that's how we basically got around to just going ahead and just choosing the medicine over the actual insurance.
Dr. Raulerson, one of the things that Ms. Bowen had addressed was keeping up with her prescriptions. And one of the complaints that you hear all across America, from every demographic, every income, every political persuasion, is the high cost of pharmaceuticals. And it seems to come home as an issue when we realize that the same pharmaceuticals are sold in other countries, Canada, Europe, at a significantly reduced rate. Why do we have that difference in costs?
I don't think there should be that kind of differences. I think the pharmaceutical companies in the United States are way out of line in what they're charging for medications. You know, just in the last year, epinephrine, which is a life-saving drug, EpiPen for children with allergies, the cost of it became prohibitive for many families. All children who have severe allergies have to have EpiPen, one at home, one at school, one with them, and the price went way up to over $600 for one, and families could not afford it. I think that we need to put some more controls, and I think that's another reason why the federal government needs to be involved. They need to stop pharmaceutical companies from charging these exorbitant amounts that none of us can afford. And that's one of the reasons that health care from Medicaid or Medicare is so expensive, because they're trying to cover these expensive medications that just a few years ago were not expensive.
And Mr. Rickard, I'd like to bring you back in the conversation, because a critic would look at that issue and say, specifically in the case of the EpiPen, as an example, the problem was that the FDA kept denying all the proposals for generic alternatives. So the competition that could have been there was never approved, and it created essentially a monopoly with one company to produce all those pens. So there is a case where perhaps regulators can have a good value in keeping costs in check. And in this other example, they actually contributed to a monopoly. Thoughts?
Well, that's exactly right. One of the things that you brought up a little bit earlier that's important to note is how complicated healthcare is. It was famously said by our president, who knew that healthcare was so complicated. Well, I think any of us on the panel could have easily told him that healthcare is extremely complicated. You've got the pharmaceutical industry, which is extremely powerful lobbying group in DC with lots of money and lots of influence in Congress. You have the hospital association, you have the physician groups, you have the insurance industry. All of those people, and then you have the medical device manufacturers. All of those folks have to get together behind some plan. As Dr. Franks mentioned a few minutes ago, having 17 days to put together a plan, which is what the time frame that the Republican plan on the ACH was not enough time. I was around long enough to know back in the 90s when the Clinton administration was trying to do healthcare reform, and that was probably somewhere, I think, over a year that it took to try to get that in place before that imploded, again, because of the competing interests. So to answer your question, yeah, there's a lot that can be done. The question is, with the influence that is that's provided by the different lobbying groups, can you come to consensus that's going to affect all people of the United States, and in particular in Alabama, so that we can have affordable health care and that doesn't negatively affect their bottom line? Because that's what we're looking at to a large degree, is the bottom line of some of these industries.
And let's stay with that topic, Mr. Carnes, because Dr. Franks raised a really good point. He talked a few moments ago about the town halls. People come out and say, I want all these things that I like in the legislation. Is there a point perhaps that Congress should, say Washington, Congress, the presidency, should look and say, you know what, there has to be a limit, because if we provide all these services and we provide quote unquote free services, which economically speaking are not free, someone's paying for them somewhere, it's created such a big, giant system that it's not cost effective. And we sometimes mask it because we say, well, the premiums are low, but only because they're being subsidized. The premiums aren't really low, it's just there's a third party paying for them.
I would come at that maybe from a different angle. I think we've discovered in this rapid process, the attempt to undo the Affordable Care Act, we've discovered how extensive it is and how many protections it provides that people have really kind of come to take for granted, and they've sort of overlooked them. I think, I dare say all of the panelists would agree that rising costs, particularly as they play out at the premium and copay level for the consumer, the out-of-pocket costs are a huge problem. But that's a problem that we could focus on with laser intensity and fix by bringing pharmaceutical companies to the table, bringing other parties, and really hashing that out. But the idea that the whole Affordable Care Act is a disaster is just a concoction. It is, I think we've learned, and these town hall meetings have been an expression of that. People realize that if we were to chuck the Affordable Care Act, we would all lose the protections against being denied coverage for a pre-existing condition, being charged more because we're sick, being charged more because we're female. Those kinds of things seem like the distant past, but it was only 7 years ago when that was the law of the land. So already we've become accustomed to these new protections. So I would say that my hope is that in this process of trying to dismantle the Affordable Care Act, we'll be able to focus in on the real problems. No one is saying that it was a perfect law, because no law is. It's just that over time we ordinarily have an opportunity to fix the problems in a big law like that. And I hope that that's where we're going, that we'll be able to pull back and say what really needs attention.
And on that topic, Dr. Frank, so Mr. Carnes mentions a really good point here, and it was about 80 years ago where this whole process that was created before World War II under the FDR administration, where a third party essentially pays for a lot of health care coverage. It's created perhaps an entire couple generations of consumers who aren't cost conscious. As an example, Local 15 has taken a look at just in a 3-mile radius where the same MRI could cost anywhere from about $325 to $1,700. And when a consumer walks in and simply makes a copay, they're not cost conscious. Are we beyond the point where, if, as Mr. Rickard said, if we had the luxury of time, could we crack this whole thing open and say, let's take this back to the beginning? And is there a better way we could set a system up so it benefits everyone with great health care, it isn't expensive, and maybe those entities that overcharge find themselves out of business?
Well, 2 points I'd like to make. One, our rhetoric has sometimes in the past few weeks gotten us in the way of coming up with a workable plan. The emphasis on the words repeal and replace versus repair have polarized the kind of discussion that could lead to how do we take what we currently have and improve it without it having to be a GOP plan or a Democrat run plan, which I think gets in the way of us coming up with a plan that really does represent the needs of the people of this country. Now, the second point, which you raised, if there's some skin in the game, we tend to pay a little closer attention to what the costs are. And what we found is that patients that have some responsibility for copay or other cost of their care will often make better decisions about what they need versus what they might like. And what we find in medicine is that we often can get to 80 to 90% certainty in a relatively economical way of doing tests and delivering health care, and then use a little bit of time to determine, do we need to do more sophisticated tests? When we want to go to 95 or even 100% certainty of what's going on, that's where many of these very expensive tests come in, such as an MRI, et cetera. And so what we're finding is that for people with back pain, for instance, MRI is usually not indicated, certainly early on, but often is done as part of a routine workup. If patients were required to pay a certain part of the healthcare cost consistent with their income, they, together with their doctor, could make a decision. Should I get the MRI now, or should I wait 2-3 weeks, see if I don't get better with some more conservative, less costly treatment? And if not, then go to the MRI. So these are the kinds of approaches that take a little bit of time to work out. And if we can pull out some of the political process from these types of decisions, I think we'll find that it works better.
Doctor, frankly, I'm stunned. You would think there'd be politics in anything that comes out of Washington.
Well, I don't know how I came up with that.
Let's go back and go back to our honest broker here, Ms. Bowen, because let's assume for a moment, and God forbid it happened, but let's assume for a moment that you became very ill or you had a significant injury. What would you do today? If something happened, how would you go through that process so that our viewers can look at it and go, wow, that is a challenge?
Honestly, I would probably, with this being my junior year in college, if it was to happen like as we speak today, I would probably have to take off school for a while and put whatever money I put in school, I would actually have to put it into everything when it comes to my health. Because in order for me to finish school, my health has to be great also. So I feel like I would have to sacrifice finishing school versus my health.
And those are tough decisions. And before we move on kind of the next topic, Dr. Raulerson, we've discussed pharmaceuticals already, and we can perhaps point our finger at big pharma, the pharmaceutical companies, but also consumers are to blame for some of this, because we often hear at Local 15 doctors telling us a patient will walk in with a magazine ad ripped out and say, this medication right here, you need to prescribe this to me, I need this right now. Have we, all of us collectively, particularly media, have we created a situation where our country is more medicated than it should be, and it's tougher for doctors to sometimes say no?
I think that's an excellent question. Part of this has to do with the doctor-patient relationship. I've known most of my patients for a long time, and I respect them and they respect me. When a patient comes in with one of those ads in hand, I can give you an example. Her child had flat feet, and she came in with this ad where she could get this $600 insert in her child's shoes, and wouldn't Medicaid pay for that? And so we sat down and we had a conversation about flat feet and how you treat them, and that you could actually get shoe inserts at one of the local stores for $12, and there was no reason for her to want something that cost several $100s, which she really did not need. And I think that has a lot to do with where medicine is going, because a person needs that medical home, a medical home where the doctor knows them and the nurse knows them, and you can discuss as patient and doctor, what is the best thing for you? And then when the patient says, well, my child has a headache, don't you think we should get an MRI? I can say, well, let's start with a good physical exam. And then after I do the physical exam, I say, you know, your child doesn't have any signs of a brain tumor. Let's talk about some of the other causes for headaches. And I find that that approach works very well.
Mark. Doctor, I want to go back to you for a moment, because you addressed earlier, and I'll be with you for a moment, Mr. Ricker, but one quick follow-up. You addressed, let's say, the politics in Washington. One topic that seems to have widespread appeal across the political spectrum and the public at large was coverage for pre-existing conditions. Can you talk about how and why that is so important?
Well, if you have diabetes, hypertension, and let's say you've had a heart attack, and you're 50 years old, as Mr. Carnes said, 8 years ago, you might not even be able to get health insurance no matter what you wanted to pay for it. You're at high risk of having an additional problem, and your cost of health care out of pocket would potentially be astronomical, particularly relative to the amount of money you make. If you have those kinds of health problems, you're probably not able to hold a full-time job because of the difficulties that that kind of health would cause. So if you can spread those costs over a large population, such as young, healthy people, then the cost to any one individual is much more reasonable. And so those that are unfortunate enough to have serious health difficulties can get insurance, just like those that don't have health problems. Now, we do the same with auto insurance with some gradations. We expect that everybody will have auto insurance. And so if you have an accident and somebody runs into you, you can pretty well assume that they will have auto insurance. We expect that in our society. That's part of the cost of having a car. It's not too different from saying, if you're going to be a member of our society, we expect you to have health insurance. One, because it's a societal good. If you're healthy, you're going to be more productive. If you take care of yourself and you get good health care, you're going to contribute to society, you're going to contribute to the taxes that help run society, you'll be less likely to be disabled, et cetera. And so it benefits society in addition to benefiting the individual.
Mr. Rickard, I'd like to bring you back in the conversation. I think you've got some things you want to address.
Well, actually, a couple of things. I agree with Dr. Franks. One of the things that's important to note is that people have access to health care. The problem is that providers such as Dr. Raulerson or the University of South Alabama Health System are providing that health care uncompensated in many cases. So what is happening right now is that, going back to Dr. Frank's example, which I totally agree with, is that health insurance is about risk. It's about spreading the risk over many, so a young person helps offset the older population that's going to cost more. People have access to health care. It's just episodic, and it's not quality care because you don't go back to the medical home, as Dr. Raulerson was mentioning a moment ago, which is a better method of providing care, having one primary care physician where you go to. The problem that Dr. Raulerson brings up, which I think is important to note, is the fact that she doesn't have the time under the current situation, which is a fee-for-service reimbursement. Doctors are paid on a fee-for-service basis, so it's basically a piece rate. So she gets paid for each and every visit that she goes to, that somebody comes to her. So if Ms. Bowen comes to her, then she gets paid a set amount. What she doesn't get paid for, which is what actually the Obama administration was pushing, partly through the ACA and partly through another act, is this idea of value-based reimbursement, that a physician, that a provider, a health system is paid based on the quality of service that they provide and the value of the service that they provide versus how many times that somebody comes in to see them. That's a whole nother paradigm that we need to shift to, because Dr. Raulerson doesn't have the time, can't afford to run her small business, which is a doctor's office, if she only gets paid whatever the amount is, $40 per visit, and all she has time for is to, as you've seen probably when you go into the doctor, you see your doctor for just a few minutes and then they're out the door. They don't have the time to spend with you because it's an economic disincentive for them, unfortunately, under a fee-for-service mode of payment.
Mr. Carnes, both Dr. Franks and Mr. Rickard brought up a good point. Insurance is a risk pool. It's spread across. One of the challenges that actuarials have pointed out was under the Patient Protection and Affordable Care Act, there was a pricing mechanism set up so that there could be age-specific costs. There's a 3-to-1 limit. So a 64-year-old could not be charged more than 3 times what an 18-year-old would be charged. But statistically, people who are 64 and older spend 5 times as much in health care than younger. So what that does is it boosts the cost of a premium for young people, young adults, and they say, you know what, I'm going to pay the penalty, I'm going to bail out of the system, and it created a problem that it wasn't the balance they thought going into it. That may be one area where perhaps there should be a little more leeway in terms of pricing, and for someone who's heading into those golden years, I don't want to pay a whole lot. But
yeah, well, one response to that was in the American HealthCare Act, which broadened that range from 3-to-1 to 5-to-1, which makes the premiums unaffordable for people on the older end of the age spectrum. So we have to find a balance. I personally would not mind seeing higher penalties that really get the younger people into the system more quickly. I think we did a good job here in Alabama. We had a very good response from young adults on the health insurance marketplace. One thing that often gets lost and has been lost in this last round of conversations over the last 2 weeks is the fact that most people in the United States get their insurance through their work. The people who get insurance through Obamacare, so to speak, fall into 2 categories. There's a large group of people who received new coverage through Medicaid in the states that were able to expand Medicaid, which Alabama has chosen not to do, and to bring young working adults into the Medicaid population. But the other group, which is slightly less than half of the people who've gotten new coverage, have bought individual plans on the marketplace. But they're really only a fraction of the people in the United States who have insurance. Most of us have it through our work. So we're really, I think, in some of the alarm bells that people have been ringing over the effects of the Affordable Care Act have really been exaggerated. They don't, the president and others have been talking about it as if everybody is suddenly facing these horrible changes in their health care, losing their doctor and all this kind of thing. And that just simply hasn't happened. So I think we really need to clear the air, look at what the facts tell us, and then identify the hot spots, the areas that are serious concern, and go at those with full force.
Dr. Raulerson, I want to follow up on something that Mr. Carnes had just addressed, and I want to address some of the questions our viewers at home have. He addressed Medicaid, something with which you have familiarity. And one of the things that happened out of the Patient Protection Affordable Care Act was this, I'll call it voluntary expansion of Medicaid by the states. Some chose to expand, some did not. And there's been this Medicaid inequity where in the expansion, the federal government covers 100% of the costs, declining to, at least at the meantime, in the near term, to 90%, whereas some of the existing Medicaid patients are being reimbursed, the providers are being reimbursed at 75%. So it creates a bit of this inequity, and oftentimes what we've seen in many states is those who came under the expansion were able-bodied young adults without children, and there's certainly a belief that those who are greater in need, those in poverty, particularly with children, were perhaps suffering. Thoughts on all of that?
One of the things that the Affordable Care Act that was really good for children in Alabama was to increase the match for children who are on the Children's Health Insurance Program. The Children's Health Insurance Program was matched at 100%, just like the states that expanded Medicaid to adults. In our state, Alabama, we did not expand Medicaid to adults, but we have 160,000 children under partly Medicaid and partly our All Kids program who are matched 100% by the federal government. And as far as the other children are concerned, we have almost 600,000 children in Alabama that are on Medicaid, and the match is not as good as it is for those childless adults in other states. And that has caused some problems with our state being able to fund that. So there is a problem there. However, having cared for Medicaid children in a rural Alabama situation for almost 40 years, it's been a good program for children in our state. And children are able to get their well child visits, their immunizations, their sick visits. And the pediatricians who see private insurance patients also see Medicaid patients. So it's the same care. It's good care.
Mr. Carnes?
Could I just clarify something that you mentioned in your question? It's not the providers who see the difference in those matching rates, it's the state. Mm-hmm. The state gets a lesser amount of match for the traditional Medicaid population than we would if we expanded to the low-income adults. So it affects the state budget, but it doesn't have a direct effect on that.
And a quick follow-up to that, doesn't it also create a challenge for providers as some states, or if the federal government moving forward, looks for cost savings, and there's always discussions with Medicare as an example as well, at cutting reimbursement rates, that it creates a disincentive for healthcare providers to work in those fields because they say at some point the math doesn't work, I can no longer work in that field because the reimbursement, they call it the doc fix every year, and they go through this budgeting process, and each year they say we're going to reimburse providers less, and then they have a kind of a sleight of hand, it's a budget gimmick. But it creates a disincentive for healthcare professionals to work in those necessary fields.
Well, I think we would all argue that,
yes,
that reimbursements need to be better for providers, particularly primary care providers. And Alabama has stepped up. We did pick up where the feds left off. There, in the Affordable Care Act, there was a temporary increase in the primary care provider reimbursement for Medicaid. And when that expired at the federal level, Alabama picked it up. Now, because of our budget crisis last year, we had to roll that back temporarily, or Medicaid, the state chose to do that. And it was very painful. And some pediatricians' practices had to make very hard decisions about how to accommodate that. We're back up to speed with that, but I think it shows how fragile that reimbursement level is.
Doctor?
One thing I would just add is that Alabama, through a whole variety of techniques, is actually spending only about $1 for every $9 they get for the federal government on Medicaid. And so they, with help from the hospitals, from the pharmacists, from physician groups, have made up the difference. So when you say 75% has come from the federal government, another 15% has come from providers throughout the state, so that the burden on the taxpayer is only about $1 out of 9 for those Medicaid monies that come in.
There are a lot of questions we've been addressing here. Our viewers have been weighing in as well. I want to share a couple of comments we received from our viewers this evening. Ebby Nobles from Grand Bay asked, will there be more policies that meet the targeted needs of the people? And I want to address one question that came from David Underhill from Baldwin County. He asks, why can poor third world countries, such as Cuba, provide no-charge health care, but the U.S. cannot? Mr. Rickert, that doesn't seem to make sense to some people. Is that accurate? And if so, what are your thoughts?
I'm not sure if I can speak for what's going on in Cuba, but I can speak for what happens in this country. I mean, there is a cost. I don't know that the United States of America is looking to go to a single payer system, which is essentially what we're talking about, which is government run, very similar to what happens in the UK, that they have that, very similar to what they have in Canada. I don't think that the United States and the citizens of this country, as well as the different components of the healthcare system, are willing to go that route. I do think that we're more likely to stay with a market-based system, and as the rest of the panelists have talked about, there's opportunities if we could get away from some of the political rhetoric and get to the meat of the argument here and try to fix the issues that are out there. I think that's the important component. I don't personally see us ever going to a single payer government-run system. That just doesn't seem likely to me. One point I would like to make, though, that was coming back from the American HealthCare Act that failed a couple weeks ago, is that they were looking to save about $900 billion out of the Medicaid budget. $900 billion savings over 10 years was what the Congress was looking at. The important thing to note here in the state of Alabama is that Medicaid is the backbone of healthcare and healthcare financing for the state of Alabama. As Dr. Raulerson mentioned, most pediatricians, their Medicaid population could be upwards of 25 to 50%, even greater in the rural areas.
80%.
80%. Every OBGYN practitioner in this state has about 50% of their patients are Medicaid patients. And so how we finance healthcare in this state has a lot to do with what comes out of the federal government, in particular what happens with Medicaid. And so this whole idea of financing, how we finance Medicaid, and that 70-30 match or the 90-10 match or 100% match has a lot to do with whether you're still going to have a University of South Alabama health system with its level 1 trauma center and a burn center and a neonatal intensive care unit. If we didn't have Medicaid in this state, and if we didn't have the funding that comes through that, that affects the private paying patients. That affects the people who have the Blue Cross Blue Shield coverages of the world, and it affects them just as much as it affects a Medicaid patient or a Medicare patient.
Let's discuss real world challenges once again with Ms. Bowen. So let's just assume for a moment that the current Patient Protection Affordable Care Act is repealed. If you have a chance to look in the camera right now and talk to those in Washington crafting the replacement bill, as a young adult, can you tell them what are the things that you say, I absolutely should have that I can afford? Give us just a few examples of what you think is important for a young college adult.
Well, as a young college adult, I feel that the main things we need is healthcare, of course, but when it comes to things like dental, like I recently had a cap loose out of my mouth, and there's no way that I can go to the dentist and get it treated or anything because I don't have health insurance. And I think one big issue also is when it comes to the Obamacare, the whole thing with that is I applied under it as a student because, yes, I am a student. And they still charge me at least $200 for for the whole insurance. And what I was trying to understand is how can they charge somebody who's not in school, who's in school and have no job or anything? Like, everything I do throughout the day basically helps me pay for school as like resident assistant, Pell Grants, things like that. That's how I'm paying for school. So how else? My big issue is how do they expect me to pay for? How do they expect me to pay for insurance if I'm in school and I'm not working, but I'm basically doing things to make sure I stay in school also? So that is my big concern with that. So I really wish that they would sit down and think of a plan that would help others, because when it comes to people who are older, like senior citizens, yeah, they're required, like they already have these type of things, but when it comes to my age, we don't. And that's one of the biggest issues. That's one thing we need, because when I applied, like a long time ago, they was like, well, are you pregnant or anything? And my grandmother was like, no. They was like, well, that's the only way that we could really provide you with any type of health care that you really wouldn't have to pay for. And so that really doesn't make any sense that you have to actually go get pregnant or something just to get help.
That's a good point.
And Dr. Franks, not that this is the ideal situation or solution for Miss Bowen or young adults like her in that situation, but as a stopgap measure, aren't there some medical schools or dental schools that would say we have students who are willing to provide some amount of care to someone in that situation at little or no cost, and it's part of our training?
Well, as Mr. Rickard said, the universities across the country that have medical schools and other health profession programs often have clinics where they will provide health care at a sharply discounted rate or even at no cost to those that have no health insurance and no real source of income. The problem is, as was mentioned earlier, it's often very sporadic. And people come in when they are having a crisis, and the opportunity to do preventive care to avoid the crisis is lost because they don't come in on a routine basis. So having access is more than just having an emergency room down the road. It means having the means to cover health care so that children can see Dr. Raulerson, get their vaccinations, get preventive care, so they have an opportunity to live the American dream. Now let me just go back to the issue of Cuba and some other countries. As a society, some countries decide it's more important for us to provide health care for everyone and preventive care, which often can be less expensive than the high technical care. And so if you go to Canada, you often have to wait several months to have an MRI because they don't have as many MRIs. If you decide as a society, we want a lot of MRIs because we don't want to wait for an MRI, well, that's going to increase the cost. If you're going to have the latest technology so that if you have a serious healthcare problem, you have that technology right at hand, well, there's a cost that goes with that. Now, many of the countries have decided we can't afford that. And so in Britain, for instance, several years ago, if you were over 65, you would not get dialysis. And a friend of mine, his mother and boyfriend were in England. He came down with a reversible kidney disease that shut down his kidneys. He was over 65. They would not do dialysis with him, and he died. If he'd been in the United States, wouldn't have been a problem. So those are decisions that, as a country, you make of how you distribute and use your healthcare dollar. In the United States, we have felt that high-end technologies, many of which we export to other countries, are very important. And so we pay for those, but it raises overall the cost of healthcare.
Mr. Carnes, I want to address something Mr. Rickard had mentioned earlier, and I hope I properly state what he had said, but he certainly kind of raised the concern about how quickly they tried to put together the GOP plan earlier this year, and that it really is a complex process and it takes some deliberative negotiations and thinking and so forth. At the other end of the scale, and you've addressed that perhaps the Patient Protection Affordable Care Act should be repaired as opposed to replacing it. But there's also a sense of urgency because 2/3 of the states today 33 now have fewer providers in 2017 than they did in 2016. 5 states, including Alabama, have only 1 insurer available. And now news that was just breaking in the last 24 hours, Humana has announced it's going to pull out of providing service in eastern Tennessee. So Knoxville and 16 counties in which 40,000 people currently are served the exchange will potentially be without a provider this time next year. So there certainly is a sense of urgency that they have to provide, let's call it the medical term, we need some emergency triage here to keep this thing going if people are going to have coverage, and whatever that looks like, whether it's a new provider or changing the rules, allow people to move on to they can certainly buy health insurance on the individual marketplace, but they don't have the federal subsidies. Any thoughts of where we stand in terms of how quickly we have to make repairs or replace?
Well, it's certainly an urgent matter. I mean, we have to bring those insurance companies to the table, as we do with the pharmaceutical companies and other major industry participants in the healthcare system. But there is a way to solve this problem. I mean, and again, we're talking about, with the marketplace, we're talking about, in most states, a fraction of the people who have insurance. In Alabama, we're accustomed to a Blue Cross monopoly, essentially. I mean, because by far, most people who have insurance in Alabama through their work have it through some form of Blue Cross. The same holds now on the marketplace. But competition would be a very good thing. It could drive costs down. We hoped originally that the marketplace would encourage competition from the beginning. I think we were reaching a point where that was going to turn around. I think we were also going to see premiums begin to come down, because it was predicted that there would be an adjustment period, that there would be instability for a couple or 3 years while the market got accustomed to the new system. So I don't think we gave it time to mature in that sense. But I would be very optimistic about an effort to identify the most pressing problems and then take a broad team approach to fixing them. I think the idea that, I'm really glad that this controversy over the attempted repeal has revealed so much that had been hidden about the Affordable Care Act, because I think we have discovered that it's a far-reaching act. Dr. Franks mentioned and Mr. Rickert mentioned the importance of preventive care. There were many provisions in the Affordable Care Act that encourage and reward preventive care. And so as we see those play out over time, that's when you start to see the rewards, the benefits of better health and lower costs, because more intensive preventive care brings down costs because it prevents those high-cost, late care incidents that we all know so much about.
And Dr. Franks, before I want to get Dr. Raulerson back in the conversation first, I want to follow up on something that Dr. Franks had mentioned, and I actually put those words in his mouth, but I really talked about the politics in Washington. And while we talk about, let's say, the execution of any healthcare system, behind that is the cost. And sadly, what we've seen is that the savings that were to be realized through the Affordable Care Act didn't come about because of politics in Washington. Everything from more than half the projected savings were supposed to come from the community living assistance services and support system, which ended in 2013 because it's actuarially unsound. The medical device tax was repealed. The Cadillac tax was postponed to 2018 and then 2020, and the individual mandate penalties were reduced. So all these financial savings have gone away because of some back-end negotiations, if we want to call that politics. And so it certainly puts pressure on coming up with a solution, because even if it's an ideal system, it's going to collapse from under the finances. Thoughts?
I really am not the person to figure that out, but I can say this, that the replacement that was put forth was going to save most of the money on the backs of the Medicaid program. And having been a physician caring for children on Medicaid in our state is essentially insurance for children. Did you know that children are the least expensive of all medical care? And also, Medicaid children cost less for their care than children in Alabama who are on Blue Cross Blue Shield. So you're already talking about a program for children that is cost effective, provides the same care for those children as any other care. So why would you decide to develop a system that would save money off the backs of the health care for children? And that's what would happen.
And Dr. Franks, that's an easy question to answer because children don't vote. Something to add on all this?
Yes. Back to the dilemma you talked about with insurance companies pulling out of the Affordable Care Act. Right now, with so much uncertainty, if I were running an insurance company, I'd have great concern about making a substantial financial commitment without knowing what the future is going to be over the next several years. And so that complicates whatever decision Humana made. Second, which we decided as a country not to do, was to offer a public option with the Affordable Care Act. And it may be that what we find in some areas where there's not competition, that the public option is the solution that has both political as well as financial acceptability. Now, if you look at California, they've been able to maintain a number of insurance companies in every district, and they have been able to sustain the Affordable Care Act. So I think we have some lessons to learn from states that are thriving under the ACA, as well as from states that are having difficulty. And during this time of uncertainty, it would be very hard for an insurance company to stick their neck out any further because many of them have lost a lot of money as we've gotten to a steady state.
Mr. Ricker, almost out of time. Any closing thoughts here that perhaps we should consider?
I think one thing that I'd like to mention is healthcare as part of the economy. As we talk about reforming healthcare, whether it's repeal or replace, whether it's the Affordable Care Act or whatever the new act may come out of this year's Congress, healthcare is 20% of the U.S. economy. It has a huge impact. So to the extent that you make tweaks over here has an effect over here. And so the issues that I think that were very clearly seen as the American Health Care Act was brought out is that what kind of effects it was going to have on the economy. And going back to what Dr. Frank said, and again, as you talk about the exchanges, insurance companies are businesses. They're in business to make money, and they are not going to invest hundreds of millions of dollars into a market that's unstable. And at this point right now, it's unstable. You could argue how we got to the point of being unstable. I think there's probably blame on both sides, whether it's the Affordable Care Act or whether it's the Republican Congress that was taking away some of the tenets and some of the things that were holding up the Affordable Care Act. I think there's plenty of blame to go around. I think the bottom line is, as it's been said many times, I think we can fix this. It is fixable. Unfortunately, I don't think it makes sense to throw the baby out with the bathwater in the case of Affordable Care Act. It seems like we're looking for a political victory, which that we threw it out, and not fixing the policy issues. That's my concern at this point.
Ms. Bone, I'm almost out of time, but I got about 15 seconds for you to give us a closing thought.
I think the whole way that they can basically fix all this is they have to market it right. Product, placement, promotion, and price. That's their issue. And if they can do all that and just sit down and get it together, I feel like everybody will be able to afford it.
And one day, we'll all be working for Ms. Bowen. We're going to have to leave it there because we've run out of time. And we've had a spirited discussion on a wide variety of topics. And you can take a look at the political spectrum. On one end, there is let's have greater government control, top-down approach. The other end is greater freedom for the cost-conscious consumer. Is there something in between? Hopefully, we've answered some of the questions you've had tonight. On behalf of our panel, the fantastic crew of Local 15 News, I'd like to thank you at home for joining us and being a part of tonight's discussion. We're continuing the discussion on our Facebook page at facebook.com/Local15 News. Make certain you watch our late news for coverage of this roundtable and all the day's breaking news. In closing, we'd like to salute our military, law enforcement, firefighters, EMTs, and other emergency personnel for their service to our communities and our nation. I'm Mark Hyman. Good night.